Thank you very much for coming to this session. So my name's Tim Harris. I work at the Royal London and Barts Health, and I have an interest in trauma and resuscitation. The two talks that Alistair and I are going to give really both have a bit of a historical flavour. Recently, the thrust on resuscitation has been looking at blood and blood products, and what I wanted to do was just go back and look at the volume and blood pressure components of damage control resuscitation. So this is really just to remind us that trauma is an epidemic of our age, and it's an epidemic that's largely occurring in the developing rather than the developed world. And the two things that are killing people are neurological injury and blood loss. Neurological injury we're certainly improving our care of. TBI is getting better and better managed, but blood loss we've come a long, long way. And I'm interested in this because I look after a couple of hospitals distantly in the developing world, and it's great to be able to give a lecture in the first world where significant elements can apply in the third world. And really what we're going to theme now is damage control resuscitation. So what we need to do is minimise blood loss. We need to identify the patients that have significant blood loss, and then to those choose the group in which we're going to apply a damage control surgery and damage control resuscitation or hemostatic resuscitation. At the end, I'm going to introduce you to the concept of hybrid resuscitation. I think those of you with a military background will be quite familiar with this. Those in the civilian world perhaps less so. So we aren't talking blood here. There's not time in 45 minutes. So passion and knowledge are often inversely proportional. We don't argue about what we know. If we've got a great randomised trial to guide us, we can agree. We fight about belief. Now, some of what I'm going to say is belief. I would love to stand here and give a purely evidence-based talk, and perhaps as research continues we will. But at the moment, this is my interpretation of the literature. So our early goals in resuscitation, and this is, I'm not going to deal with the airway, this is cardiovascular resuscitation. We want to identify tension physiology, whether it's a pericardial or a pleural tension that's causing a loss of preload. We want to stop bleeding. The best blood any of us can have is our own. So we want to preserve circulating volume. And we can do this by looking at patient movement, by splintage, by pressure and hemostatic dressings, and rapidly identifying the source of bleeding so our surgical and radiological colleagues can fix it. And we can't talk about preserving circulating volume without starting in discussion of CRASH 2. Absolutely fantastic. The largest trial, randomised trial in trauma ever done, run out of London by Professor Ian Roberts and his colleagues, over 20,000 patients, and in penetrating and blunt, in the south and the north, the east and the west, the rich and the poor, giving 1 gram over 10 minutes and a second gram over 8 hours reduced the chance of death in both hemorrhagic and non-hemorrhagic trauma. This begs the question, of course, whether tranexamic acid has some properties beyond its ability to strengthen clot, which is currently much discussed. And it's interesting, isn't it, to just remember how factor 7A was entering our minds so much 10 years ago, really on the basis of just case reports, and it's a somber reminder of the marketing skills of companies, I think. Factor 7A is, I'm not saying has no role, but its role is limited, and it's not proved itself in robust trials. So let's start and look at what we can do in the emergency department and pre-hospital to preserve volume. So we'll often called to see people on the streets of London or wherever, and our temptation is often just to roll that patient onto the back, have a look at them. But as time's gone on, we've developed a much more reasoned approach. This man's lying on his side. He's got a reasonable position for his airway. The team can assess him, get some access, formulate a plan. And once a plan's been formulated, then to move him with minimum resistance onto an orthopaedic scoop, which you could see opened again to minimise movement, and on which he will be more comfortable. And that's because as we roll this man, the pressure of that roll is taken on our pelvis and our arms and our chest. And if your pelvis is disrupted, that movement of 150 degrees will potentially impact that fracture and displace both the fracture complex and the clot associated with it, potentially worsening blood loss, causing further hypotension and a general deterioration. And of course, it might not just be the pelvis that we damage by rolling our patient. Perhaps if the man had a spleen like this, perhaps that roll may push a fractured rib into it, or perhaps the movement, if it's not gentle, may in itself disrupt clot. So we talked a little bit about splinting fractures this morning with the pelvic lecture, so I'm going to miss this out other than to say that we have little evidence for the pelvic splint, but we have good anecdotal experience with it as a way of minimizing displacement, particularly of an open book pelvis. Of course, we splint fractures to try and reduce movement, to try and stabilize the injury, both the neurovascular and the clot associated. And it's interesting, I tried to look, I said, well, where's the best evidence that splintage actually alters outcome? And it's a shame that we don't have better trials, but the best or most striking data I could find was going back and looking at the Thomas splint, introduced in World War I, and just look at the rate, the fracture of femur mortality prior to the introduction around 80%, after around 8%. Now I can't say perhaps there were other interventions, but that seems to have been the main one at the time. And it's simple for us to forget how very basic manoeuvres can have a huge impact on patient care. And we often forget temperature. Now, I don't want to get into a debate about the role of temperature and traumatic brain injury, but temperature has an effect on coagulation, and we know that patients over a whole range of injury severities do worse if they're hypothermic. We know that this is multifactorial, and I think there's sufficient evidence of this to put stress on maintaining temperature pre-hospital, which we can do with bubble wrap, which we use in EAA, which is the East Anglian Air Ambulance, where Alistair and I work in London Hems, and I think perhaps in a lot of the ambulances that you guys work in. We can preserve temperature with blankets or with simple chemical or electrical reheaters that sit upon the chest. And in the ED, of course, we've got more sophisticated things like the bear hugger. We can preserve circulating volume with tourniquets. These have been around for 300 years, fell from favour with concern about local tissue damage, and really made a recurrence with the CAT tourniquet in 2006, led by the horrific blast injuries of the current conflicts. Now again, I can't give you any randomised evidence, but we do know from observational data that when they're placed prior to shock, they increase survival against matched controls. We can also apply pressure dressings, and again, in recent years, we've seen a growth of local hemostatic agents, HemCon, QuickClot, Celox, and again, technology led very much out of the local conflicts. And again, I can't give you randomized evidence of any outcome, but we do know that they work in terms of controlling local hemorrhage. So, to get on to damage control resuscitation. This is really a strategy of resuscitation that encompasses permissive hypovolemia with associated permissive hypotension, and it's derived from our knowledge of acute trauma coagulopathy and the potential harm of some of our resuscitation fluids. It's a strategy really for the critically unwell patient, and teasing out that critically unwell patient is quite a skill. And we have some military and some civilian evidence, but none from randomised trials. And our goals were to preserve volume, which we just did as a brief introduction, to identify the source of bleeding with imaging, which we're not going to discuss today, and then to fix it, which we're not going to discuss today. So the key components of a damage control resuscitation philosophy are a period of permissive hypotension. If you give products to make sure, if you give fluids to base that around blood products, a so-called hemostatic resuscitation, and to combine that with tranexamic acid, and to avoid vasopressors, which we have some animal data for at least, increase bleeding and mortality. This will lead to a period of damage control surgery, aiming to preserve life and limb, and definitive resuscitation in the intensive care unit. So, shock and blood pressure are intertwined in medical history. But while blood pressure is a useful sign and can guide us to critically unwell patients, blood pressure or hypotension and shock are not interchangeable terms. We know that shock is about cardiac output, about tissue delivery, and shock is an inadequate delivery of oxygen for that organism in that pathophysiological state. And of course, major hemorrhage can be associated with shock or occur without shock. And while there are great definitions of what major hemorrhage is, I think the best one I saw for you as trauma team leaders to apply to a patient in front of you is to ask yourself, am I going to give more than 4 units to this patient over the next 4 hours? And if so, to assume that that patient has major hemorrhage. I know that may not be a good research term for coming back looking at the number of units, but that's no good to us when we're stood up as trauma team leaders. So hypotension, commonly defined as 90, and we will revisit that, does not equate to shock. Shock can occur with a blood pressure above that level, and frequently does, and normal oxygen delivery can be preserved at a blood pressure below that level. And remember that the relationship between blood pressure and cardiac output only bears any sort of linear relationship at the extremes of volume, when you're getting to a blood loss of 45 or 50%. And it's because the final act of homeostasis of your body is to preserve blood pressure, and you will preserve your blood pressure unto your death. So we have very powerful mechanisms. We hang on to our sodium, we hang on to water, we vasoconstrict, we also transfuse out of our liver, our spleen, our low pressure circulation, and we centralize our circulation into our high pressure circulation. Now, there's some very sophisticated tools that have been developed to help you tease out those critically unwell patients. A little bit like pediatrics, where we've got wonderful tools, these tools perform no better than an experienced clinician. So I don't know if any of you use them in your practice. We certainly don't where I work, because the evidence is an experienced team leader will perform at least as well of those tools in identifying critical illness in trauma shock. What we do know, however, is that failure to identify this group and to appropriately resuscitate them worsens outcomes. This is a key skill of a trauma team leader. Now, many of you will be familiar with this from your ATLS training. ATLS has undoubtedly brought some wonderful things to medicine and to patient care. It's standardized care, it's given us a language, it's translated some good early research into practice, but I tried hard to understand where the ATLS manual came up from this, and I looked for the evidence, and then I looked for how it compared to published data. And I'm afraid the pigs are flying here, because I really don't think this translates well into practice. And what I'd like to do is just share with you a little bit of data from TARN and from the American trauma databases. Now, this totals around 1 million patients, 870-odd thousand from the US alone. And what we can learn looking at this database is that patients in stage 1 to 4 shock, as defined by the volumes in the ATLS manual, the mean pulse in all of those groups is under 100. There was no change in the mean of those groups. It doesn't mean, of course, some patients right at the extreme, of course they differed, or elderly or more frail, but the mean was within normal limits, didn't change, nor did the GCS. And indeed, the median, because it's not normally distributed, blood pressure remained above 120 throughout those 4 groups. So if we allow ourselves to be guided purely by that table from ATLS, we will significantly underestimate shock and blood loss. Now, Eastbridge, and this is similar data now again from TARN, looked at how mortality changed with blood pressure. And mortality in trauma starts to increase at a systolic of around 110, not 90. And for every 10 millimetres of mercury you fall below that, so the mortality will increase by around 5%. So if we are going to pick a point for hypotension in trauma, I think it should be 110, not 90. That is at least useful as a flag to an increased mortality. And similarly, we know that for pure blood loss, a pure hemorrhage model without associated pain, anxiety, fear and drug therapy, young and not so young adults can lose 20 to 25% of their circulating volume and have no change in their physiology at all. And indeed, we know from certainly our own observation that patients, particularly with thoracic penetrating trauma, may become bradycardic long before they become tachycardic. So, ladies and gentlemen, I'm not saying ignore blood pressure. Of course it's useful, but I think hypotension, particularly persisting hypotension, should be taken as a pre-terminal sign rather than the identification of a sick patient. We need to pick up these patients earlier on in the natural history of their disease. Now, I trained as a physician before I trained in intensive care, before I went to emergency medicine. And I remember one of my defining moments was my boss, when I was doing physicians training, said, "So I don't know where you're going to intensive care, you don't need all that technology. It's rubbish. A good doctor can identify shock from the end of the bed. You don't even need to touch the patient. Look at their behaviour, look at their skin." He was a fantastic mentor, but in this, I think he was wrong. We can all identify the patient near death, but we can't identify those that are in cryptic shock, those that are just beginning to fall off the ladder. And indeed, this has been reasonably well studied, and we're not even good at deciding if a patient's got a high output, low SVR, or low output, high SVR. And our ability to identify patients with impaired oxygen delivery is no better than tossing a coin. It doesn't mean we're bad clinicians, but good clinicians involve all of the data they can. Data from blood gases, data from imaging, and data from various bits of technology. However, in the ED, just remember, the kidneys are a wonderful canary of your circulation, and urine output really is a good guide to early resuscitation. Now, I've put this graph in, which I'd like to acknowledge and thank Rupert Pearce, who's Professor of Intensive Care at Barts Health, gave me this. And this is just to bring home to you that mean arterial pressure and oxygen delivery, or we could have cardiac output, are not linear related. We cannot use our blood pressure to inform us about oxygen delivery and about shock. Just a doggy graph. So how do we then identify patients that are critically unwell in whom we want to institute damage control resuscitation strategies? We look at the injuries. We estimate blood loss from those injuries. We look at the pattern. We look at changes with physiology. We look at imaging from FAST and CT. And we bring in metabolic parameters from our venous or arterial blood gas. And strong iron gap, bicarbonate, base excess and lactate are all good predictors both of survival versus non-survival and good prognostic indicators. And lactate clearance particularly is a very good indicator of survival. Although I think we've got a long way to go before we know exactly how much lactate should clear over what unit time, both in sepsis and trauma. So mixed venous oxygen saturation. Many of you, I'm sure, will work in intensive care anaesthesia or the emergency department, and this will be a common measurement for you to make. It was perhaps popularised above all by Manny Rivers in his sepsis work. But ScVO2 is a reasonably good measure of global oxygen delivery, and certainly relatively non-invasive, and one that's not difficult for us to get down in the ED. Just to recap, we normally extract around a quarter, 25% of the oxygen we deliver. So if we take a sample of blood from our superior vena cava, we'd expect it to be around 75% saturated. As that lowers, particularly down to 50 or 55%, so we've moved over into anaerobic metabolism. And just to remember that as it becomes higher, perhaps above 85, 90%, so that implies that there's a failure of extraction. So survival is a J-shaped curve with ScVO2. But we know from animal data that as we bleed the animals out, so our ScVO2 will drop. So it can help us with our monitoring and our resuscitation phase. So let's look specifically at permissive hypovolemia, permissive hypotension. This is a resuscitation strategy, a temporary, short-lived resuscitation strategy that sees us prioritise the correction of coagulopathy and allowing strengthening of clot over resuscitation with restoring tissue perfusion to all our organs. In other words, we are delaying, deliberately under-resuscitating our patients to prioritise coagulopathy over end-organ perfusion. Now, the idea of fluids carrying harm and worsening bleeding goes back a long time. I think many of you will have seen the quote from British surgeon, I think Mr. Cannon, observing that delivering fluids increased blood loss and suggesting that this should be delayed. The thing is, through the 50s we started to do a lot of physiological experiments. We started to model shock, and that model was often rats having their tails removed, and a very simple, very pure blood loss model. And that was coupled around the time of the Vietnam War and beginning of understanding multi-organ failure. And Shires and his colleagues then popularised the idea of 3-to-1 resuscitation, i.e. 3 units of fluid in to 1 unit that was estimated of loss. And indeed, this improved resuscitation on the intensive care, improved outcome at least. And that was the paradigm that was popular and dominant within the medical field when ATLS was written. So ATLS picked up this high volume resuscitation, the 2 litres then think about blood, that many of us grew up with and were trained in. However, we have some concerns with that high volume model. We know that some fluids, at least particularly saline, might promote acidosis. If the fluid's not warmed, it may promote hypothermia. It will dilute hemoglobin, it will dilute our clotting proteins, and above all, that burst of fluid into a vasoconstricted patient with trauma will see a rapid rise in blood pressure, and that will be a rapid rise in the pressure across a clot. And we know that that clot forms reasonably slowly, reaching about 80% strength over 1 hour. So that act of vigorous fluid resuscitation may force that clot away and may worsen hemorrhage. So what evidence do we have for hypovolemic resuscitation? I guess we have to perhaps dedicate this more to our small furry friends than human studies. There are upwards of 70 trials in the literature that look at various models of resuscitation, either a specific blood pressure or a specific volume. And what we've learned, and for those of you that want the reference, Mapstone, I think, did this a really good meta-analysis of this, and I'll put that up in the next slide. We know that if we bleed animals out to a critical volume and circulatory collapse, they will die without fluid. So this isn't about no fluid to anybody. Of course, enough blood loss, circulatory collapse, of course you need fluid resuscitation. But in those that have a subcritical hypovolemic insult or a critical bleed, then we need to restore them to a blood pressure and a volume that is below that with which they would normally exist. So hypovolemic, hypotensive resuscitation. And we know that is associated in animal studies with better survival, less bleeding, and less organ failure. And this is out of Mapstone 2003's Journal Trauma, which is a meta-analysis of those studies. And you see, this isn't about no fluid at all, this is about limited fluid. So, the Cochrane collaboration looked at fluid resuscitation 10 years ago. They looked at three trials that compared early versus delayed fluid resuscitation, and then they looked at 3 trials that looked at larger versus smaller volumes of fluid resuscitation in hemorrhagic shock. Not all these studies were trauma, and they came to the conclusion that they could not make a recommendation to the clinicians either on time or volume of fluid. So let's look at what they looked at. So the most important trial here, or the one that's had the greatest effect, is now nearly 20 years old. So this is Bickel and colleagues, a southern United States trial, a randomized by days of the week, took patients who were hypotensive as defined by systolic below 90 and randomized them into normal, i.e. ATLS-themed fluid resuscitation with normal saline crystalloid, or delaying their fluid resuscitation until they reached the operating theatre. And this paper showed a mortality advantage, which was significant whether you look at p-values or confidence intervals, in favour of restricted fluid therapy. Now, this is a few caveats to this trial. One, 68 patients died pre-hospital and there is no data why they died. Two, 22 patients, that 8% of the cohort that were randomised into the low volume group actually got fluid. And that isn't, and I don't think there's anything foolish there, because that's probably the doctors and paramedics identifying that group of patients that had a critical bleed that needed some fluid. And all the trials that have looked at fluid have found that when you get into the operating room or into the emergency department, the blood pressure in both groups is equal. Your homeostasis, your ability to mobilise fluid out of your interstitium, to auto-transfuse from the low-pressure system, from your venous system, from your spleen and from your liver. But a fantastic trial, fantastic effort, and changed medicine. Next trial, Richard Dutton and colleagues in shock trauma decided to look at 2 systolic blood pressure targets, 170. They chose to look at both penetrating and blunt disease, and they recruited rather slowly. In fact, Professor Dutton called the trial to a halt early, way before he'd reached the numbers that he wanted to. And this was done after 3 and a bit years because practice in his centre was changing so rapidly, he felt that they could no longer continue the trial with clinical equipoise. And fortunately for the patients and unfortunately for medicine, the mortality was so low that the trial was underpowered to show any difference. The UK did attempt a trial, randomised trial of early versus delayed resuscitation, just a few miles north of here. A really brave trial, really brave effort to look at patients with moderate to severe trauma. Unfortunately, compliance with the trial protocol was so low, with only 31% of patients randomised to fluid getting it, that actually we can draw no conclusions from this trial. There is a very interesting ongoing trial. It would be particularly interesting for those of you involved in anaesthesia. I Googled this just a few minutes ago to make sure it hasn't reported, and it hasn't yet. This is a trial of randomised intra-operative resuscitation for trauma thoracotomy or trauma laparotomy, with the groups randomised to a map of 50 versus 65. The authors published an interim analysis of their first 90 patients. There was no mortality difference between the groups, but the group randomised to less aggressive fluid targets, less aggressive blood pressure targets, received less blood products, less fluid, had less bleeding and less coagulopathy and less bleeding-related deaths. And yet again, theme from all the trials, whatever target blood pressure we set, the body is a far more powerful beast, so the blood pressure differences are the same throughout both groups. There's a little indirect evidence perhaps to support it. The mask suit popularised many years ago, the idea being that it would centralise your circulation. Unfortunately, trials that have looked at this have shown it to be associated with adverse outcome. Now, whether that adverse outcome is indeed because it rapidly centralises circulation and increases pressure, whether it's because it increases afterload, or whether because it takes so damn long to put the thing on and delays getting to hospital, I don't know. But it is associated with a poor outcome. So following Cochrane, NICE got in on the act, and NICE had a look at the trials we've just been through, but then decided, we're going to bring in the animal data, and we're going to bring in a couple of looser trials. So they brought in some observational studies, a couple of systemic reviews which looked at ALS versus BLS, so weren't really looking at fluid but looking at the theme of intervention, and they included this Canadian cohort study which looked at fluid or not on 360 patients. And as I'm sure all of you are very familiar with, the NICE technology appraisal number 74 came out in favour of permissive hypovolemia and recommended resuscitation against either a radial or carotid pulse using small boli in recognition of the that our hemorrhagic shock and trauma sees a very steep compliance curve. So a little bit of fluid increases the blood pressure quite rapidly. And that, of course, dominates a lot of our practice today. Just remember when you're looking at this, although we're discussing blood pressure, we do know that interventions increase odds of death. Every intervention we do pre-hospital increases the odds of death by about 2.6, or at least in this particular analysis they did. So it's hard to know really if the benefit is the blood pressure target, the fluid target, this is the pre-hospital studies of course, or just moving the patient more rapidly into hospital. And of course there are problems with hypotensive or hypovolemic resuscitation. You know, hypoperfusion of your organs is not good for you, and if we starve an organ of oxygen for a period of time that is dependent on that organ, your age, it will have a period of dysfunction and will fail. And we don't know how low we should let the blood pressure go, and we don't know how long for. And that's really seen the development of the idea of hybrid resuscitation. So we know that blast injuries dominate the recent conflicts in Iraq and Afghanistan. We know that blast injury is associated with significant tissue damage and also significant lung damage. And we know that this is associated with tissue hypoxia. So, important down, a series of experiments. I'm only going to look at one of these, but the take-home message is that periods of hypotension preceding more than 1 hour in blunt trauma with blast injury are associated with an excess mortality. So let's look at one of these trials. I think these are very, very elegant. So this is a pig model, 4 groups. So pigs were randomised to a blast injury or a sham blast or no blast, and all pigs had a 30% blood volume loss through a femoral artery cannula. The pigs were then randomised to be resuscitated into piggy normotension at 110 or piggy hypotension at 80 using fluid aliquots of saline. The primary outcome is survival at 8 hours, so a very short period compared to what we're interested in. So all 8 animals that were non-blast and had normotensive resuscitation lived. 5 out of 6 of those without the blast and hypotensive resuscitation lived, no significant difference. But if we look at the animals that had the blast injury, 4 out of 6 lived when they were subject to normotensive resuscitation, but in those that had a hypotensive resuscitation, everyone died, and that was highly significant. Now, this is a non-human study, it's a small number of animals, but it must raise questions on the period to which we can allow permissive hypotension to run for. And this is the data that I've just verbalised, presented graphically for those of you that find a graph easier to follow. So sham, normotension, blast, normotension, sham blast, hypotension, and blast, hypotension. And similarly, those that had a normotensive resuscitation recovered their acid base better. And you can put the same thing for oxygen delivery and the same thing for lactate. So the only fluid I'm going to mention in this talk is hypertonic saline. There are a lot of trials currently in place looking at catechlaamines, looking at fluids. There's the first trial, there's the citrus trial, and the colloids in severe trauma trial. I googled them at lunchtime and those haven't reported yet. But we have reasonable data now for hypertonic saline. If you remember in the 90s, there was excitement that hypertonic saline may be associated with an improved outcome in trauma victims. Then Jamie Cooper, my old boss from Australia, did a very elegant randomised trial of the group that should benefit most. He randomised patients with hypotension and traumatic brain injury defined by a GCS of 8 or below to receive a bolus of hypertonic saline or Hartmann's based resuscitation. So a slightly hypotonic fluid against a hypertonic fluid, and he found no difference in outcome. Then in 2009, we saw a large American study looking at hypertonic saline in dextran to be administered pre-hospital, stopped both for futility and for an increased early mortality, suggesting really that the role of hypertonic saline in trauma resuscitation, this is not for traumatic brain injury, we're not discussing the treatment of intracranial hypertension, this is as a resuscitation fluid. So I think it's fair to say now that hypertonic saline has no place outside trials. So what conclusions can we draw from this? So hypovolemic hypotensive resuscitation is the paradigm and is supported by NICE. But we do not know what blood pressure to aim at, and arguably it doesn't matter because our body will act to homeostase to its own levels. We do not really know how long we're to maintain that period of hypotension for. There is some evidence with blunt trauma based on animal studies that perhaps an hour is a time to think about moving on to a more definitive resuscitation. So your job as team leaders, as trauma clinicians, is to balance the risk of organ injury from a hypoxic hypoperfusion of a consequent upon hypovolemic resuscitation and balance that with the damage of worsening the bleeding from a vigorous resuscitation. We also need to remember that actually the big clinical trials that looked at hypotensive resuscitation were actually performed before we had the data to support blood product-based resuscitation. So we really don't know how those two things interact. We also don't know if the benefit of hypovolemic resuscitation is just simply because we give less crystalloid. There's a bit of data from looking at blood-based resuscitation to suggest actually it may just be harm of particularly saline and the fact we're giving less saline, and that may be an important signal here. I'd like you to remember hybrid resuscitation as a concept. I don't think there's enough evidence to support it, but there is evidence that proper goal-directed resuscitation following blood pressure control is associated with outcome. I've got that trial and other slides if you want to ask questions, but I'm not going to discuss it here and now. We also don't really know what to do with traumatic brain injury. We can all roll off the mantra of hypoxia and hypotension being associated with a worsening mortality in traumatic brain injury. We don't really know about the early resuscitation and what goals to aim at. We also don't know how this is affected by elderly. We would suppose elderly people may need a higher blood pressure, may be more frail, may tolerate a hypoxic injury. We can think these things through, they make intrinsic sense, but we really do not know where to set goals. So hypovolemic resuscitation is reasonably easy to apply pre-hospital and in-hospital when your patient has settled into a reasonably stable pattern. But in those critically unwell patients with massive blood loss and ongoing bleeding, it is painfully difficult to actually resuscitate to a set blood pressure. And we find ourselves even titrating small boluses of fluid, overshooting and undershooting. My military colleagues tell me that they overcome that in part by some vasodilation, by giving small boluses of fentanyl, warming the patient and balancing that fluid administration with analgesia. I have no experience of that, but it's an interesting concept. And just remember that your patients are very vasoconstricted, so you will get quite a marked blood pressure spike from a little bit of fluid. I'd like to close this by just advertising the European Trauma Shock Survey. If we were having this conversation in Paris, Milan, and we were asking, what's your practice? How do you manage trauma? What do you do pre-hospital? Many of the clinicians would say, well, I give a high volume resuscitation. I give blood products rather than colloid, and I start NORAD early. So I visited the couple of trauma centres in Paris, and it was really interesting to watch them start. So they had NORAD ready for when the patient arrived. They had high volume crystalloid as well as blood products ready for when the patient arrives. So two things. One, we're going to compare our outcome at the London with theirs, just as it'll be a dirty comparison, but interesting. And two, we'd like to advertise the European Trauma Shock Survey, which I'm going to ask Keith if he'd be kind enough to allow me to just send this link to you all if there's a group email, and I would ask you all to contribute to that. It'll help us. It's not going to answer things, but it will inform future research. So I'd like to thank you very much for your attention. Do you want any questions? Or? So thank you, ladies and gentlemen.